Good morning, ladies and gentlemen. Good morning to all the early birds here in the Congress. Today we continue with the CPR competition, and the first team to welcome the scene is coming from Denmark. Guys, are you ready? Let me also introduce the juries today. Today we've got Koen again joining us. We've got Jennifer, who's working here in Italy, and we've got Pauline quietly in the background. Thank you.
Some time with the bed.
Yeah.
Right?
Hi, team from Denmark. Who is the team leader?
That's me.
All right.
Simon,
We were told that we could get 2 seconds to check the bed, because we're not familiar with this
All right.
type of bed.
Go ahead.
Thank you.
1,
Okay.
2, 3.
Jeg er simpelthen bare de orange. Vi skal bare have hovedet... Jeg tjekker på, at du kan få hovedet af.
Ja.
Ja, okay.
Er den i bund?
Er den i bund, og er den låst? Det er den nu.
Jeg tror, man skal...
Ja. De skal bare klikkes ned på begge sider.
Okay.
Den kan ikke komme længere ned end det her.
Nej.
Okay.
Yeah.
Who's the team leader?
Me.
You are? Okay. Maybe get your team here for the briefing.
Yep. Tabitha?
I will be setting you a scenario,
Vi skal have det til dem der.
and I will ask you to, if there's any questions afterwards. Okay? So the situation is, the staff nurse in the emergency department is asking for your urgent help with a quickly deteriorating patient. Okay? The patient is named Helge.
Helga?
Helge, yeah. Is that Danish? Could be, no? 77 years old. She's brought in by, in the emergency department by her husband. She complains of some shortness of breath and dizziness on standing. She has high blood pressure and osteoarthritis. On first assessment, she's weak, pale, and epigastric tenderness.
Sorry, Anna.
Epigastric tenderness in the stomach region. So what we need to do for you is to assess her urgently.
Yeah.
Could you repeat
Right.
that scenario in brief?
Okay, I'll do that as a briefman of my team as well. We've got a 77-year-old female who's brought in by her husband. Her name's Helga. She's quickly deteriorating in the emergency department. She's got shortness of breath and dizziness. She's described as being weak and pale and with a tenderness in the epigastrium. Medical history of hypertension and arthritis.
Yes.
All right.
Are there any remaining questions before we start? Because when you start,
Has she taken any medication today? He's taking any extra medication?
I don't have any information about extra medication.
Okay.
Is the husband with her?
We are in the emergency department.
Yeah,
the husband is with her, yes.
Yeah.
So he's here.
The husband is somewhere, but not immediately available.
He's not here.
No.
Okay.
Oh, yeah.
Any further questions?
No. Okay.
Okay. Then we start now.
Thank you. Okay. Helga? Helga, are you all right? Any response?
There's no response.
Right. Right. So I'm just going to check for a pulse and any signs of breathing.
You don't feel a pulse.
Okay, start. She's in cardiac arrest.
Yep.
Morten, you do the ventilations and compressions 30 to 2. Lena, if you could put on the pads.
Yeah.
Ready?
Simon, I put in an IV line.
Thank you. And if you could prepare 1 milligram of adrenaline.
1.
As soon as
I
you're
will
done.
prepare 1 milligram of adrenaline.
Thank
please.
you. Afledning, Lena.
It is on pedals.
Okay, so,
Okay.
yeah. Stop for analysis. Start while charging, shockable rhythm.
Stop. All clear. Start. Shock number 1 is delivered.
Thank you. And as if you could prepare also 300 milligrams of amiodarone.
I will prepare 300 milligrams.
Thank you.
of
Okay, so we've got the 77-year-old female quickly deteriorating in the ER, and now she's in cardiac arrest. She has got, we've shocked her once on a shockable rhythm, And we've got the meds ready.
We got adrenaline and amiodarone.
Thank
ready.
you. And a working IV line.
A working IV line, yes.
Okay, thank you. So, Morten, when you get the chance, if you could intubate this patient, please.
Yes, will do.
Thank you. All right.
One.
What do we know about this patient?
Two.
She's got hypertension and arthritis.
Okay.
Her complaints before the cardiac arrest was shortness of breath, and she was brought in today.
Yes.
Okay. So no long periods of immobilization.
One.
And no current history of trauma or
No.
operations of any
time?
kind. Okay, thank you. Right, so we're preparing for the second analysis. Time.
One.
Time still have a
Two.
minute.
Arterial blood gas.
Yes, thank you, Anders.
Along with that.
Right, we should talk about the
Reversible
the
causes.
reversible signs. Thrombosis could be likely. She's a 77-year-old.
One.
Yeah.
A shortness of breath. It
Two.
could also be a pulmonary
blood gas
embolism.
taken.
So a thrombosis
Definitely.
is very likely.
Arterial blood gas.
Tamponade, not very likely.
gas.
Yeah,
She's
arterial
not
blood gas.
undergone
We
any
don't have one.
surgery
Okay.
recently or any trauma. Pressure pneumothorax. Could you actually listen the next time that
Definitely.
we'll check for that, and also when she's in,
20 seconds.
Okay.
intubated.
10 seconds.
5, 4, 3, 2, 1.
Stop.
Second pulse.
Start while charging.
Stop. All clear. Shock number 2. Start. Shock number 2 is delivered.
So that's the second shock.
Okay.
We've got the meds ready.
time.
All right.
Straight while-
Talking about reversible signs, Morten, if you could intubate
I'll
this
intubate
patient, because
Yep.
it could be hypoxic as well. We haven't got any stats on her from this morning.
30.
Hang on.
Two.
We don't think so.
Yeah.
Yeah.
Thank you. So,
No signs of pneumothorax.
okay. I'll just have a quick look. Is there any signs of bleeding?
No.
No. So, no signs that no suspicion that she should be hypovolemic. So that's
30.
hypoxia, hypovolemia.
Rising.
Two.
I'll take the
Intubated.
tube.
Thank you. If you could check for the tube placement, Lena.
9.
And
10.
also, if we could get a capnograph on the tube. Do we have a reading on the capnograph?
We don't have a capnograph currently.
Ventilations
Okay.
on both sides.
10.
Thank you, Lena. We've checked the arterial blood gas for hyperkalemia and hypothermia.
10.
Does she feel warm? She came from home today.
She
Not
feels
found
warm,
outside.
normal.
Thank you. Okay, so that's the 4 H's. We've got thrombosis, tamponade,
Thrombosis is
toxins,
like
no
a-
recent history of medicine.
No.
No, okay. And then the
9,
pressure
10.
pneumothorax. You had a listen.
Yeah. there's no
Okay, so
9.
ventilation sounds on both sides.
Exactly.
Thank you. So the most probable cause should be thrombosis, either cardiac or pulmonary embolism. So we should
10.
maybe we should fetch a doctor who can
5.
do the echo.
4,
9. 10.
3, 2, 1.
Stop. Is there a pulse?
You feel a pulse.
We feel a pulse.
Got a
Great.
Oh, you feel
Guys.
no, sorry, you feel
Oh,
no pulse.
Okay, start.
No
Sorry.
pulse. Okay.
That's
Don't charge.
Oh,
It's a
no,
non-shockable rhythm.
Sorry.
Sorry.
9. 10.
Right, so Tabitha, if you could give the adrenaline. We've prepared 1 milligram of
10.
adrenaline. We're now in the non-shockable rhythm of the algorithm.
10.
Right,
9. 10.
thank you, and flushed. Thank you. So if you could prepare another milligram of adrenaline
9, 10.
as soon as you're ready. So this 3 cycles in total, 2 shocks, and now a non-shockable rhythm on the third.
9.
We've got the meds prepared, and the most probable cause is a thrombosis.
Yes.
We should get a cardiologist down here. Elena, if you could contact the cardiology
I'm
department
calling the cardiologist.
to do an echo, maybe to check if there could be any signs of stress on the right side of the heart. We should consider thrombolysis with this patient if it's a pulmonary embolism.
Definitely.
In case of that, we should actually also consider a prolonged duration of CPR.
9, 10,
All right, guys, anything we're missing?
9, 10.
We've been through all of the reversible courses.
Yes.
We're prepared for the next shock or non-shock with meds.
9, 10.
All right. So, Morten, how does it feel when you're
9,
ventilating?
10.
Any problems?
No,
Any
it's
any
soft.
resistance?
No resistance.
10
Thank you.
9,
seconds.
10,
Thank you, Lena.
5,
9,
4, 3, 2, 1.
Stop. Is there a pulse?
You feel a pulse.
We feel a pulse.
I've got a pulse.
Yeah,
Yes.
okay, guys, we've got return of spontaneous circulation, so we should do a prompt ABCD walkthrough. Is the patient awake?
The patient is not awake.
The patient's not awake. Is she breathing
No.
spontaneously?
He's not breathing
No,
spontaneously.
okay. So you
I'm
continue,
supporting her.
and if you could check tube placement again, Lena.
Yeah.
And if you could do 10 to 12 ventilations a minute.
Ventilations on both
Oh,
sides.
right, that's the A. On B, Lena, if you could do the auscultation and percussion of the chest wall.
The saturation's on.
Thank you. The saturation.
How's the auscultation?
Is there any reading on the saturation?
The saturation is 95.
And the
95.
auscultation?
Thank
Is it
you.
normal?
And
Bilateral breath sounds.
the respiratory rate is controlled by us, so
Yeah.
we'll continue that. You did the auscultation.
Yes, it was normal.
Normal. Thank you. So we'll do the C, blood pressure and the pulse, please. Thank you. And Lena, the auscultation.
Pulse rate 80.
Thank you.
And the
Auscultation.
the auscultation of the heart? Was it normal?
Normal.
Yeah.
Normal.
And we've got, could you get another wide bore IV line on the other side?
IV line.
And also, if you could order a 12 lead ECG on us.
12 lead ECG.
Yeah,
Yes,
Lena,
I
if
will
you could
order
check
that.
the capillary refill time.
Yes.
Thank you. I'm looking for any deformities
4,
of the chest, any
5.
deviation of the trachea.
Normal.
Normal, okay.
I
3
ordered
seconds.
ECG and
Thank you.
The
X-ray of thorax.
Thank you.
Capillary refill, 3 seconds.
Thank you, Lena. Right, and the equality and depth of chest expansions.
Normal.
Normal, thank you. So we've got C covered. Let's do the E. She's not waking up. Cool. Is she waking up?
She's not waking up. No,
She's not waking up. So she's any response to pain? No. So she's unresponsive on the output scale. Let's check the pupils. Lena, could you do that for any reaction to light?
Yes. How are the pupils?
And the blood glucose to beta.
Good
Normal reaction to light.
Normal reaction to light. All right.
And
so
equal?
Equal.
And equal.
so you on the output scale, otherwise a normal D, and then we'll do the E. I'll expose the entire patient, look for any signs.
I'll take a temperature.
Thank you. Any signs of edema, rashes, bleeding? All right.
You're
So,
the urine
in
catheter.
conclusion, this patient who's now been in cardiac arrest and not waking up, she's intubated and unresponsive, so we should get her to the ICU, and we should talk to the cardiologists about making the PCI as soon as possible on the suspicion of a cardiac or a pulmonary thrombosis.
It should be.
Right.
They don't take this one.
And in the meantime, we will...
Urine catheter.
a urine catheter would be great to monitor the output.
An extra saline water on this IV access.
So, saline on the other side. Yes, that would be nice. Right.
Okay, we'll stop here. Thank
Thank
you
you.
very much.
Yeah.
Applause.
Yeah.
Get a good choice.
We'll
Okay.
go.
Jeg har fået en mail.
Nej, det var fandme godt arbejde. Sådan til Peter. Nu skal vi simpelthen ned og sidde.
Den bliver hård i morgen.
Jamen, i morgen er det et barn.
Godt kæmpet.
Kan du rykke lidt frem til Vita?
Ja, så vidt. Ja. Ja, thank you.
Det var så ansigt.
Wow, group from Denmark. How was that?
Sweaty,
Yeah,
but fun.
it was fun.
Yeah.
You enjoyed it.
Yeah.
Oh yeah.
Definitely.
Okay, team leader.
Yeah.
How did it go for you?
Well, actually, pretty much as planned. I had a team who knew what to do, and with the pre-assigned assignments, there was a little misunderstanding about the pulse, whether or not there was a pulse underway. But otherwise, I think actually it went more or less as planned.
Good, so you're happy.
I'm happy.
Team, how did it work for you?
It worked good.
Yeah,
We had a good team leader who could assign jobs for us. So
Definitely.
we were not at any point unemployed. We already knew what to do, but Simon were good to put us to work.
Yeah, he planned ahead all the time, so we knew what we had to do in a moment. I like when he asked
Yeah,
us to
definitely.
prepare for intubation, and then later asked me to intubate. We already had it planned out.
In clear orders, it was easy to understand. He was summarizing. We knew where we were all the time.
No, I must say I was very impressed. I was mainly impressed on the feedback. You asked for something to be done and the team fed back into it, saying this has been done, and that was really well done. What do you think was her problem? Why did she go into cardiac arrest?
Well, my main suspicion was on the pulmonary embolism. It could have been a cardiac thrombosis as well, but she had no previous history of cardiac illness. She had the hypertension and the arthritis. So it could have been either one of them. The other reversible causes, we went through them during the resuscitation trial, and I guess that most of them were ruled out pretty quickly. So the main suspicion was on the thrombosis.
And how did you arrive at this thrombosis?
Well, the symptoms to begin with, I didn't have any time to actually talk to her because she was in cardiac arrest. So all I got was the history of her general color. She was pale, she was feeling weak, and she had chest pains, and that could be either the
But there was
abdominal
and
the
it
epigastrial.
can
That
also
could be
anaphylaxis is also a
Yeah.
slight possibility, but there was no mentioning of her.
no new
taking
medicine in the
medicine.
history, no antibiotics.
Okay,
She didn't even have an IV line, so I guess
it happened very quickly.
it did.
Okay, so for your diagnosis of pulmonary embolus, is there something, I noticed that you didn't have a look for any varicose veins to maybe confirm that diagnosis as to where that embolus would have come from. Why did you not look at her lower legs?
Well, I probably should have. I guess I was caught up in the actual resuscitation. And then afterwards, when we did the ABCD, we went through the whole and we exposed the patient. I could have done that during the resuscitation as well.
Because, as you say, with her gastric problem, it may not have been a pulmonary embolus, but that wasn't actually ruled out totally.
No.
So this is a point to think about next time when you're doing it, is you really need to do your very quick ABCDE as you're going through your 4H's and 4T's to really be sure that that is the thing, or you may come up with two things. You know, this person that has she has osteoarthritis, so obviously the medications she's taking, she's come in with this chest pain but epigastric tenderness, should also be a warning sign. So this is the take-home message for that I'd like to, don't just rule out that it's only one thing, because it could be a couple. I was interested into your asking to have an advanced airway put in, but this happened after the second shock. Why didn't you think of that earlier, or was that in your plan to wait and see if the first shock
That was actually in the plan
effective?
to begin with. We needed to establish the basics to get the compressions and the ventilations going, getting the IV line, getting the defibrillator ready, and then when all the basics were in place, then we sort of built another layer on top of that with the intubation. So that was actually the plan from the start.
Okay. I was very impressed. There was a slight problem with the defibrillator there on the supposed third shock, which never eventuated, and you as a team leader had an eye on that, and you went across and you discharged it safely. I think that was an excellent maneuver that you did as a team leader. You certainly were looking after the safety of your team, so I'm really impressed with that. Now, take-home message for next time, don't just stop at the first one. Think of other things. It could be a couple of things together and you need to rule out. And I would continue to, if you wanted to do a, say it was a pulmonary embolus, you could have asked for an echo fast to be
I actually
done.
told Lena to contact
I
a
contacted
doctor
them
with the capability to do the
during the CPR.
do the echo
Fantastic.
while
Okay.
we were doing CPR.
Because then that will confirm and then you can go
Yes.
down the
Exactly.
other road. So, all in all, very impressive. Continue like that, but just the main thing is think next time it could be something else as well. All the best.
Thank you.
Ladies and gentlemen, let us continue with the competition. The ERC has been working very actively trying to stretch the borders of Europe. And as a result of that, now we can welcome on the stage the very first team from the Middle East. Please welcome the team representing the United Arab Emirates. Ladies, Ahmed, please come to the scene. Hello, your time is up. Welcome, guys. Where's the others?
They are putting the mics inside. They say that's us.
I understand.
Okay.
I apologize. A small technical delay due to the consideration about the microphones. In the meantime, would you like to tell us a little bit about your team then? Oh, you've got your mic.
I have one, yes. Okay, United Arab teams. We are 5 members, team leader, and 4. All of them from emergency response team. All of them are paramedic.
Excellent. How long have you been doing the courses in the UAE?
We started the courses earlier in UAE, maybe in 2003, but for the team, they are fresh. They are just like 2 months on the courses.
Wow, that's really fresh. Okay. Yeah. Let's see how effective your training is, and let's see what the team can bring along here. Okay, guys.
Thank you.
Let me introduce you to your lead judge, who is at the other end of the scene. Thank you.
Hi. Hello, team. Please step forward. You are the team leader?
I will be the team leader.
Okay, very good. I will present the scenario to you.
Can we first check the bed and have time for
you
preparation?
You can, yeah.
Okay, here's.
بسيطة. عرفتي اللوك؟ هذا انشد. هذا تشيك. اوكي. The equipment is ready.
هذا كله موجود.
Okay.
Very soft.
Okay. Comfortable?
Yes.
Okay.
Are you ready?
Okay, we are ready.
Team.
We are
The scenario is that we are in the emergency department and a staff nurse is asking your urgent help with a quickly deteriorating patient. The background of the patient is she's named Helga. Helga, aged 77. She's brought into the emergency department with her husband. She complains of some shortness of breath and dizziness on standing. She has high blood pressure normally and osteoarthritis. On assessment, she is weak, pale, and has epigastric tenderness. And you are asked to urgently assist.
Okay, can I repeat the scenario?
Repeat it, yes.
Okay. I have a case in emergency department, 77 years old. Her name is Helga.
Yes.
She came with her husband. She is complaining from epigastric pain and pale and dizziness on standing, and she is hypertensive patient.
Hypertensive.
Hypertensive patient.
Yeah, in
right?
a history.
In a history,
Yes.
yes. Did I miss anything?
Osteoarthritis.
Osteoarthritis, and
Yeah.
with osteoarthritis. Old age, 77. Okay.
Yeah, okay. Do you have any questions before we actually start the scenario?
Are you ready, team?
Yes.
You hear the scenario?
Yes.
Okay.
We are ready.
Then we start now.
Okay. Is it safe to approach?
It is safe.
Helga, can you hear me?
There's no response.
Oh, there is no response.
No.
Okay, Doctor.
1, 2, 3. Any sign of life? Any
No
breathing?
signs of
any
life.
pulse? No. Put the patient on the ground quickly. Start CPR. Secure the airway.
الباقي.
Good quality CPR. Aya, attach the monitor and let me inform immediately if we have a rhythm.
Okay.
Rima, push a little bit back to have a space with this patient.
1, 2.
Good. Continue, attach the monitor and let me know. Rima, prepare your equipment beside us here. I think we need immediately to put an IV access, so to insert the cannula,
Okay.
while we are checking what we have here.
Monitor attached.
1.
Monitors attached. Stop
Cool.
CPR. Continue CPR. Okay, we have a shockable rhythm, ventricular fibrillation. Aya, we need to shock the patient. Maximum joules, 360, start with it. Now you will prepare the equipment.
Yes. 1.
Okay.
2.
Charging, clear the airway, continue compression. Stop compression. Talk, continue compression.
Continue CPR. Okay, that's good. Now, Rima, insert
Yes.
IV cannula. And when you insert the IV cannula, I need to take some sample, blood sample, please. Well, the patient is complaining from epigastric pain. Anyway, we'll take the routine investigation, complete blood count, renal, cardiac enzymes, shortness of breath, 77 years old. So I think we need D-dimer also to exclude the thrombosis. You will continue CPR, good quality, Salama. Aya, make sure to switch with her next time.
Okay, clear.
Once you are ready, you can intubate the patient as well.
IV inserted and
You
blood
insert
sample
it.
sent.
Take the blood sample and let me know. And VBG as well. We need to know the arterial blood gases, as well as quick electrolytes from it to know the level of potassium. She's pale and weakness and dizzy. Okay, good. Try to intubate the patient. Once it's intubated, it will be synchronized. And also with the tube, we can attach the capnography. Aya, now
Yes.
the patient is pale as well. Please prepare and do 500 cc normal saline
Okay.
as a fluid now. You can bring this here
Yes.
beside the
لا
patient.
must wait. LMA.
Once it's 30, give the tube.
30 seconds left.
Okay. 130, count loudly, Salama. 130, we'll give 2 rescue breath as the patient is not intubated
1,
yet.
2.
Good, the fluid is
Okay, fluids
attached.
connected.
Okay. Aya, make sure to switch with her once we have time to switch, if it needed, and if still the patient is arrested.
5 seconds left. My hand on the pulse. 2, 3, 1.
Okay, stop CPR. Continue CPR. Okay, the patient is still in shockable rhythm, ventricular fibrillation, which means we'll give the second shock. Okay, second shock, 360 joule. Now,
360.
immediately after the shock, we'll
Clear the
switch together
oxygen.
again.
Continue CPR. Charging. Stop CPR. Shock limit. Continue CPR.
Okay, good. Now try to intubate the patient using the LMA. Okay, Rima, let me know immediately if we have any result from the lab, especially for D-dimer and for cardiac enzyme as well.
Investigations were sent.
Salama, to exclude any kind, well, 77 years old with osteoarthritis. It's difficult to have toxins, but I want you to check with the family. Do you have any family members around? No. There is no family members around, so we cannot actually judge this, but anyway. For the patient,
22,
for the shortness of
23,
breath,
24,
we'll secure, we'll
5,
keep oxygenation
6,
good.
7, 28, 29, 30.
Okay, tube is attached.
Capnography is attached.
Capnography is attached. Okay, good. So we secured now the airway for this patient. So in case of hypoxia, fluid is running still. Still we are in the first bolus, the 500. Okay. Fix the tube in place. Now, Salama, once the tube is fixed, please check by auscultation and do the bagging and see if it's in the right place or not. Rima, since you are free, we have given 2 shocks. In case we need the third shock, please prepare 1 milligram adrenaline, 300 milligram amiodarone.
Okay.
Be ready to give it immediately after the third shock. Okay?
30 seconds left.
30 seconds. Prepare medication. So now we have given 2 shock. We are passing toward the third one if needed. So we will check the rhythm. Immediately we will switch after this.
Okay.
So Salama, you will take.
1
Okay,
milligram.
keep now the
adrenaline.
medication. Be beside, please, the defibrillator.
Yes.
10 seconds left. My hand on the pulse. 5, 4, 3, 2, 1.
Stop CPR. Continue CPR. Well, it's still shockable rhythm, ventricular fibrillation. Give the third shock, 300,
And 60.
360.
360. Clear the oxygen. Okay, you're intubated.
It's VTAC, actually. And there is no pulse, so it's okay.
Okay, stop compressions. Shock delivered.
Continue CPR. Okay, now, Rima, the 1 milligram adrenaline, the 300 milligram amiodarone. So we have 3 cycles till now. Every cycle will confirm that there is no sign in life and there is no pulse for this patient. It was shockable rhythm. So we will continue. Do we have any result from the lab?
Not yet.
Not yet. Okay, so let's think about it, guys. For the tube inserted and you checked, can you check the trachea, please?
And 1 milligram adrenaline given.
1 milligram adrenaline
And
given.
300 amiodarone.
Okay, and we hear both sides, and there is no history of trauma. It's unlikely to think about tension pneumothorax or tamponade. However, we can ask for echocardiography or someone with ultrasound to do quick review to exempt the cardiac tamponade from the picture. But anyway, it's unlikely. For toxins, we don't have the history. Thrombosis, maybe epigastric pain. Epigastric pain sometimes is a typical presentation of myocardial infarction, especially inferior myocardial infarction with shortness of breath, or DVT and thrombosis at the same time. So at that case, we will wait the cardiac enzymes and D-dimer, and we should inform also the cardiologist to be ready and to book for this place. Hypothermia is the patient is, temperature is what? Temperature, sorry? Patient temperature.
The temperature is normal.
Normal temperature. So for hypoxia, we are fixing through the airway. Make sure you are any difficulty with
No
airway.
difficulty. 30
Very
seconds
good.
left.
10 seconds.
30 seconds.
30 seconds. Okay, so we must tell, we need to know the electrolytes from VPG. If it's not here, paleness, dizziness, old age, maybe. Maybe she is on medication for osteoarthritis and that's the cause of gastric pain.
10
But we should make
seconds
our
left.
best to know. Okay.
My hand on the pulse. 4, 3, 2, 1.
Stop CPR. There is pulse?
There is a pulse. Did you feel for a pulse?
Do you feel for pulse?
There is a pulse now.
Okay, there is a pulse. Good, stop CPR, do not continue the CPR. Patient is returned back to his spontaneous circulation. We have ROSC here, so we have to go through ABCD approach. We'll start by airway. Fatima.
Patient intubated, tube size 7, on depth 18. Is the patient breathing by himself?
Can he breathe?
No, it's not breathing.
The patient is not breathing, so we need to assist his ventilation. Continue, please, assessing his ventilation. We'll move to breathing. B, can you auscultate the chest? Do we hear equal air entry both sides?
Yes.
Okay, that's good. Okay, can you please palpate and percuss to see if the patient is responding?
It's not responding.
It's
no.
not responding. Even to pain, can you do some sort?
No.
No. So Glasgow coma is around 3. So continue assist his ventilation. Is it normal by percussion, both sides, resonant sound? Nothing by percussion. Please attach pulse oximetry for the patient to check the saturation. Okay, once she is doing this, you are free. Can you start with circulation? Attach, try to find the pulse, peripheral and central, and compare it both sides.
Pulse?
Peripheral and central. Can we feel it peripheral?
Oximetry, yes, 95%.
Good. The oxygen is good, actually, the saturation for it.
Okay.
Keep of this, and maybe the oxygen will be like 50%. Now for the pulse, peripheral pulse.
You can feel very weak pulse.
Very weak peripheral, central.
You can
Central
feel
is good.
Weak pulse.
Weak as well. So the blood pressure, can you attach the blood pressure? At the same time, can Salama do the capillary refill time from the sternum for 5 seconds? Check. Capillary fill time.
It's 3 seconds.
3 seconds. Okay, blood pressure.
The blood pressure is 90/40.
90/40. Have we finished the first bolus with the patient? Is it done? Finished? Can we start
No,
another bolus?
have you done it?
Yes.
Okay.
We attach the flow at 500 saline.
Okay, 500 is in.
Yes. It's still running. It's not finished.
It's, let's say it's finished.
Okay, so add another. His blood pressure is 90/40. Start the second bolus for this patient, 500
Okay,
saline
500
as well.
ml.
You can even, when you finish this, we will secure another IV cannula for this patient.
Do you want me to secure it?
And yes, okay, attach other cannula. Now we are done with the circulation, but we need to do actually for this patient ECG. We'll ask for ECG, some technician to come to do the ECG quickly, portable X-ray as well before sending this patient. Moving to D, Rima, can you do the D, disability? His glaucoma is 3, as we know this. Can you check the pupils, please?
Pupils are equal and responding to light.
Equal, responding to light. Okay, we don't have any history from this patient as we didn't deal with family, but as her, the husband maybe will guide us for this. Any drug history, any drug chart, anything? No. Nothing. We still have no idea about what she was taking. Okay, exposure. Can you expose the patient, please? Okay. Anything, abdomen. She checked the abdomen, anything, legs.
Okay.
Okay. Extremities. Anything on extremities? Normal. Nothing on extremities. That's good. Okay. Before sending this, we need also to do nasogastric tube and urinary catheter for the patient. Okay. But first, we need to expose the back. Can we log and roll this patient, please?
Yes, from this side. Aya, join us.
Okay. On 3. 1, 2, 3.
The back. Anything in the back? No. Rectal examination?
Normal.
Nothing.
1, 2, 3.
Thank you. So right now we have this patient returned back to spontaneous circulation. The patient is not breathing. Continue to support us. We will call the ICU to take this patient, and we'll need one to secure him with the defibrillation with a fixed tube as well.
Thank you very much. We will stop here. Thank you.
Thank you.
National visualization.
Okay. Okay.
Salama.
Can we move the chairs a little bit behind? Yes. Yeah. Okay.
Okay, team, how did that go?
Well, it was tough, as usual. Cardiac arrest, but we are happy that the patient returned back spontaneous circulation, which means well done, team.
Team happy?
Yes, I agree.
Okay. Did this go according to how you planned it?
Well, it's exactly the same like normal life. When we have seen this before, you cannot ever know what is the normal pattern of this. So you may have any kind of cardiac arrest with different diagnosis, and the most difficult thing is the differential diagnosis. During the arrest, your mind will start to work. Team leader is like the brain, and they are like the muscles. So every time you are looking to see what happened with this patient, why is arrested, there is no clear things, waiting the investigation forever that sometimes never arrive, which will make your life difficult. But just following the algorithm, doing the right guidelines with the right medication, buying time with a good quality CPR, will let us survive.
Good. Team, did you have already your role organized as to who was doing what and for how long?
Yes, our roles were assigned. We all knew what we were going to do coming in.
And you organized that as the team leader?
Yes. Yes, we have the rules, everyone the rules, and actually we have something we used to do, which is the defibrillation to be between two, so everyone is multitask. We are not anymore doing the one task mission, so it's multitask. They know how to use intraosseous IV for 2 persons. They know how to defibrillate for 2 persons. So they are trained at least to have 2. So in case anyone is tired, even during CPR and switching, will not bother. The free one can do the defibrillation immediately. So everyone know the first rule and the second rule as well.
And this came out very clearly that you really worked well as a team, you know, with a good team leader.
Yeah.
Thank you.
I noticed that we had a bit of a problem with the airway.
Yes.
What happened there? Who was doing the airway?
I was doing the airway. I'm trying to insert the tube, but it's not going inside. So I take it back, I ventilate the patient, I went back to do it with the LMA. Same thing, it was, I think, it's not going, it's rigid. So I took it back, I ventilate, then I try to intubate the patient, and it was successfully intubated the patient. Then it was everything, it was fine.
Okay, Fatima, I noticed actually that there was very little ventilation going on when you were trying out the twice with the ET tube and once with the LMA. This is very important that we ventilate, and the machine was actually saying ventilate, ventilate.
Yes.
So even if you can't do an advanced airway, very important to at least use your bag valve mask and give them those 2 breaths until you manage to make your advanced airway work for you. So that's your important message to take home.
That's exactly right. And even that's why I said count loud for the 30 and do 30 to 2. It was a message that I want the bag valve mask back. And they did it.
I noticed after the second shock, you had done the 2 minutes of CPR and there was the rhythm check. Are you sure that what you saw was a continuation of the ventricular fibrillation?
Actually, when I look at it, it was like ventricular tachycardia. Seems like this, and the second. But anyway, it was a shakable rhythm, and there is no pulse. So if there is no pulse with a shakable rhythm, so we continue the same. And I asked, this is a shakable rhythm, and there is no pulse, so we continued on this.
In fact, the rhythm had changed to a pair. So I noticed that you gave a very quick look for your rhythm check, and it didn't work out. So it really is important to do a good rhythm check, to be really sure. I like the idea that you asked if there was a pulse, but it really was important because by then
I do agree,
you wouldn't have gone down the road of a third shock.
Yes.
And that sort of threw you out, you know, because you had thought it was a third shock instead of going down the road to pair. So obviously you gave the amiodarone, which you wouldn't have done if you had realised from that it was a pair. Who did the cap refill?
Capillary fill time.
Okay. In your country, do you do cap refill on adults in the sternum, or do you do it on the hand?
Both sides. We can do it on the thumb or on the sternum, both.
And she checked on the thumb.
So we did it both here as well.
Okay. So, all in all, very well done. Great team leader. Good work for the team. Keep it up. Remember, ventilations properly. Remember, give it the time to do a good rhythm check. Okay, all the best and thank you.
Thank you.
The third team competing today in the first session is coming from my homeland, so please give them a big round of applause. Introducing the team from Hungary. Could you please come to the scene?
Okay. All right, team from Hungary. Team from No Sound. Yes, team from Hungary.
Yes.
Welcome. Who's the team leader?
It's me.
You are. Okay. I will be setting you a scenario, and then I'll ask you to repeat that. Is that okay? So the scenario is: a staff nurse in the emergency department requests urgent help with a quickly deteriorating patient. The patient is named Helga. She's aged 77, and she's brought into the emergency department by her husband. She complains of some shortness of breath and dizziness on standing. She has high blood pressure and osteoarthritis.
Sorry?
Osteoarthritis.
Osteoarthritis.
Like a joint problem.
Yeah. Information.
On assessment, she's weak, pale, and she has epigastric tenderness. So you're asked with your team to urgently assess her. All right, can you repeat that?
Of course. We are waiting a patient called Helga. She's a 77-year-old woman, complaining of shortness of breath, dizziness of standing, and she has hypertonia, osteoarthritis. She's weak, pale, and
she has hypertension.
Yeah.
Hypertension. Okay.
And she has an epigastric tenderness.
Yes. Is there anything else you'd like to say or do, ask or do, before we actually start?
Can we check the
You can.
equipment?
Okay, thank you.
Please do.
Check.
Take a few seconds.
Yeah.
It's for the...
Okay. We're the same. We'll be safe.
The scene is safe, yes.
Thank you. Ready?
Are you ready?
Yes, we are.
Then we go now.
Hello, Helga. My name is Laszlo Bárszky. How are you?
There's no response.
Guys? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
No signs of life.
Okay, take the patient to the floor, please.
1, 2, 3.
Guys, there is a cardiac arrest situation now. Attila, please start the chest compressions, and Vicky, please ventilate the patient. 30 chest compressions and 2 breaths, please.
100%
Gergő, please connect the monitor. And
20.
Annika, please take down all the clothes and prepare for an IV line, please.
30. 1, 2. 10. 20. 30. 1, 2.
The monitor is on.
10.
Okay, stop for a moment, please, Attila. Okay, continue CPR, it's ventricular fibrillation. Please give a shock with 200 joules, Gergő.
Okay, please remove oxygen. Continue
Okay.
with chest compressions. Please stand back. We
Vicky,
are
please
charging.
insert endotracheal
Okay,
tube
stand
and
back.
connect, please,
Everyone's clear. We're
ETC to
shocking.
capnometer. Okay, Annika, could you possibly help Vicky
Okay,
for the
please
intubation?
continue. You didn't give the shock?
Okay. I will prepare for the incubation, and after that I need your help to prepare the
Okay, to
lungs.
check the, okay. Okay, the chest compressions are good. Okay, guys, so
Okay.
let me summarize it. We are in a cardiac arrest
Sorry, you
situation.
didn't perform the shock, but it is charged.
Okay, so we can perform it.
All right, we have to charge again.
Okay, let's charge it.
All right. Okay, so stand clear, everyone. We are charging.
Kiakasztató.
Okay, step back. Okay, so no shot.
Folytatom, jó?
Okay, let's continue.
Az alatta lévőt. This one. Okay, stand back.
Okay, we are charging
No,
again.
no, this.
Okay. No. You didn't give the shock, so please continue.
Okay.
Szedd le a tappancsokat, tedd vissza még egyszer.
Szerintem az a neked, hogy ő csak riaszt a VF miatt. Úgyhogy próbáljunk meg még egyszer tölteni.
Oké. Töltsetek, mert ez kikerül.
I intubated the patient and LTCO2 is on.
Thank you.
Could you please hear the lungs?
I will hear the lungs, yes.
Oké, az légút biztosítása után megpróbáljuk még egyszer, jó?
Okay, please breathe. Stop for a moment. Okay, breathe. Now. Breathe. Okay. Okay, stop for a moment. Can I feel a pulse?
There's no pulse.
No pulse. Okay. Go on with CPR. And please, Annika, give 1 milligram adrenaline IV.
Okay.
Okay. And what can I see on the capnometer? On the capnometer.
The capnometer now is 20.
20.
Okay, are you ready?
Okay, let's. Okay, thank you. Attila, please call for give the come with the echocardiography or the ultrasound to rule out for reversible causes, please. Okay, so let's think about maybe it can be accompanied. We will.
No. Okay, we haven't here. I need to call.
Okay, call for them. Okay. Now I would like to check them.
From the
Yes.
emergency room, we have the cardiac arrest patient. We need the cardiologist with the ultrasound.
Maybe we need another device to make correct shocking.
Yes, you're right. Okay,
Last
wait
the
for a moment.
cardiologist is coming.
Okay, breathe. Is it good, the breath sounds?
Breath sounds
Is there
are
a
equal,
brand-
yes.
Sorry?
Breath sounds are equal and good.
Equal.
Yes.
Okay. Okay, any signs of hypovolemia? Is the patient pale, as you said? Yeah. Can I see any bleeding, or is there an anamnesis about the bleeding, past medical history?
You have no more information about that.
No more information. Okay. Hypoxia. Have you checked the oxygen? Is it 100%?
Yes, it's 100%.
Okay, thank you, Vicky. And please, Attila, check the hypothermia.
Okay. I take inside the thermometer.
Okay.
Temperature?
Normal.
Normal.
Stop for a moment, please. Can I feel the pulse?
You feel a pulse.
Okay, stop. Guys, we are in a return of spontaneous circulation, so let's start with the ABCDE. Is it easy to breathe?
Yes.
The patient.
Yes.
Does she has any spontaneous breathing?
No.
No, okay. I would like to check it. Take it away.
No breathing.
No breathing, okay. What can I see on the capnometer?
Capnometer is 34 now.
34, okay. So, Vicky, let's breathe the patient with 10 per min, okay, frequency. I would like to check it, and Enrico, please put on a pulse oximeter. Okay.
Normal.
Normal, okay. The respiratory rate we will give, and there is no shortness of signs of effort, I think so.
Signs of?
Effort of the breathing. No. Okay.
She's not breathing, no.
So let's go to the C, and you could please check the blood pressure. Does the pulse oximeter detect anything?
Yes, 95%.
Másik kezére tegyük.
95.
95%, okay. I check the CRT.
3 seconds.
3 seconds, okay. Please put on a monitor with a 4-line, please, and Gergő, please insert another IV line. We will possibly need it,
The
and
blood
take blood
pressure
samples.
blood pressure is 90/40.
90 over 40. Okay. Is there any sign of preload? The jugular veins, are they extended or not?
No.
And there was no hogy mondjuk a pangást.
Congestion, pulmonary congestion.
Congestion? No?
Congestion, no.
Okay. Okay, so D, Hello, Helga.
No response.
That's no response. Okay. For any pain?
No pain. No. Sorry. Pain?
For pain,
no.
there is no,
No
reaction.
Okay, monitor is on.
Okay, monitor is on. I can see this. What about the pupils?
Átváltod az érekettes.
They're normal.
They're
Reacting
normal.
to
Okay,
light.
reacting to light. Okay, Gergő, please check the blood sugar, please.
Okay.
And go on with the E. And you could please take 12 leads ECG of the patient, and I will examine.
Túlsó van szerintem. Ott túlsó nincs.
Is there any tenderness? Okay.
Normal.
Normal. Okay. So no bleeding.
Normal.
Is okay. Okay. What is the blood sugar?
Sugar is normal.
Normal. Okay. Please insert temperature meter. Okay. And Attila, after I would
the
like.
ECG
is on. Okay.
Rectal temperature meter is on.
Thank you.
Okay.
Please insert an arterial blood measure, please, and Gergő, please give in a urinary catheter. Okay, and Vicky, I would like to ask you to put in a nasogastric tube as well.
Okay, I will do
Okay.
it.
Annika, could you possibly call for the ICU that we have a patient with a return of spontaneous circulation?
Urinary catheter in.
Okay, thank you. And I would like to ask you to call for a chest X-ray as well to rule out everything.
We need a chest X-ray to the ER.
Annika, after that, could you give me a
Chest X-ray
angio
code.
tube?
Okay, thank you. Guys, do you have any idea what we should do now?
Yeah. The arterial canal is on.
Thank you. Okay.
Do we have
It's an invasive monitoring of the arterial.
We will stop here. Thank you.
Thank you.
Yeah. Kapkodjuk le gyorsan ezeket a szarokat.
Viki, ideadod nekem azt a papíruszt, amire fel lehet ragasztani. Köszi. Oké.
Sokkal mi a faszom volt?
Szerintem az, hogy ő egyszerűen riasztott a DF miatt, és nem töltött fel.
Ja, értem.
Én azon oda nyúltam.
Ati, segítesz?
Nem, valamiért nem. Azért
Nem, az volt a baj, hogy...
Nem mi volt a baj?
Szerintem az, hogy nem érzékelte a töltési utasítást, és ez egyszerűen egy VF riasztás volt, nem a töltésnek a hangja. Igen, én ezt gondolom.
Ja. Gyere ide, Laci, hogy oda mész, hogy ott maradsz.
Figyelj.
Okay, team, how was that?
Very nice.
Probably more like hard work.
Yeah.
Yeah.
Team leader, did this go according to how you planned?
Sorry?
Did this scenario go according to plan?
No, not really. There was a problem with the shocking of the patient, and it was a little bit disturbing.
Okay, what happened there?
I think that the electrodes were not correct, maybe.
Okay, who placed the electrodes?
Me.
Did you put them correctly
I think
on?
so.
Okay. The one that was on the high one here was a little too high. So if you were going to pass do a shock, electricity runs in a straight line. So it really would have missed the heart because it was too high done. Okay, so that's very important if this is your task to make sure that you place them correctly. And then I noticed that the shock didn't occur. Was there a problem with the machine or what happened?
I don't know.
We don't really find out.
Okay.
But we asked for another machine, and
Very good.
and we continued the chest compressions, which is really important. I think so.
Excellent. I saw that, and that was very well done. If you have problems with your machinery, then you go and do your chest compression. So that was very well done. Team, how did it go, this scenario on your part?
it was a little bit difficult for me because the machine is not working, and I'm afraid what will happen. But I think the chest compression is take this problem. I think.
Okay. Anyone else like to comment? Did you all know what to do? You had your role and that was going to be it?
Yes.
And you're happy with what you did?
Yeah.
So team leader, you had a good team.
Yes, I had.
That was extremely good. I noticed that you, as team leader, were at the head of the patient, guiding your team.
That I was at the head?
You're at the head of the patient.
Yeah, usually I'm there.
This is interesting because normally they're at the bottom, the feet, so they can see everything. But I want to know why you're at the head. Interesting.
I'm usually there because from that position I can see everything, and there are moments that I have to do to check the pulse, to check the patient. So I think that's my task. So that's why I'm there. At the most important things, to the pulse, the sensor pulse, the airways, and the chest compressions, and I can go in the situation if I'm required.
Okay, I saw that. I saw that you turned the monitor around so you could get a full view, and I thought that was interesting. I wanted to know why. So yes, that it works for you, and it worked for the team, so that is good. There was a little problem with safety with the use of the defibrillator when it didn't work. Can we make that a little safer maybe next time? How could we do that?
Wasn't it safe?
It was fully charged.
Yes.
Yeah.
And you could hear.
Turning, for example, turning down or up.
Exactly.
This button and.
Right. So you need to dump the charge by turning the machine up or down to dump the charge. Instead, what I saw was someone took the electrode off and put the electrode back on again.
Yeah.
So you as team leader need to be very careful about safety of your team when these things go wrong. I saw something, and I'm not quite sure why you did it. You, at one point, I noticed that you asked hands off because you wanted to check if the ET tube was in the correct place. And straight afterwards, you continued on then to do a rhythm check. Do you realize that it actually went over the 10 seconds? It was more like 20 seconds where there was nothing going on the chest?
I don't really think so. It was that I checked the tube, and after in 1 minute, I checked again the monitor because it was the end of the 2 minutes.
Okay, so what we try and do is hands-off time as limited as possible. So what I would suggest, the message for next time is, if you want to do the breath check, you do that. You go back to doing the hands-on, and the next check, you would take a short break to then check on the rhythm check when it's time. Okay? So we have to be very careful that we shorten those distances between hands-off and perfusion going on. That is your message. Team leader, you did very well. You had a few problems there, which you now know to think about and bring to your team next time. Team was very good, so continue team. And I thought it was a very well done scenario. So compliments, remember the take-home messages, and all the best.
Okay.
Thank you so much.
So that was the first round for today, ladies and gentlemen. Thank you very much for your attention and for cheering the teams. We continue at 11:30 with the next three teams who are coming from, let me see, Austria, Denmark and Croatia. So you're welcome back at 11:30. Thank you.